Good evening, everyone. Welcome to the next session of the program. And today's topic of discussion is breaking bad news. I think this is one topic we don't want to talk about, but we have to talk about because we have to really learn how do you really go about breaking bad news. Uh, Going further, I would like to ask what exactly we mean by bad news. If somebody wants to unmute and
May I?
sure, Shikha, go ahead.
Breaking bad news, if in a layman language, we can explain like if some death happens or somebody is terminally ill or at the last stage of his life or her life. These things in scenarios, we call it as breaking bad news.
Thank you. Thank you. Michelle, I think you must be really, seeing this every day because you're already into a subject. The term itself, even if it is suspected or even if it is benign tumor, I think initially it really causes a lot of stirring up. So, what is your understanding of bad news, Michelle?
Yeah, ma'am. So I just put it in the chat. So it's basically giving someone news that will alter their lives forever.
Going to change their life. Absolutely. Absolutely. Thank you. Dr. Pradeep, I think you wish to add something to the.
Yes, ma'am, anything which is unexpected to the patients. Suppose the patient has come for just simple fever, febrile presentation, and then we have to tell them now your kidney has gone into shutdown, or the pneumonitis has worsened, so patient may require ventilatory support. So, which is not a routine outcome of that illness. So, that can be a bad news.
So I'll share my personal experience with you about bad news. You know, around 20 years ago, I think it was more than that, 25 years ago, I had cough and then pain in my lower lobes. While breathing, I had pain in my chest, in the lower chest area. So my husband took me to one of his friends who is a physician. So he examined and then he said, let's get the x-ray done because the cough was persistent, pain was persistent. So he said, let's get the x-rays done. And I got the x-ray done and there was some shadow in the lower lobes, the right side, I think, or left. I don't remember exactly which side, but then on one of these sides. So he saw the x-ray and he said, uh, cannot comment immediately, but then let's start with antibiotics and I hope it responds to the medicine. Otherwise, we'll have to investigate for tuberculosis. And then he wrote the medication and I came home. You would believe that those 3-4 days for me to wait for the medicine to affect and then get the repeat X-ray done and then go back to the physician were like my whole world came, it literally went upside down. I had so many questions, who will look after my children? Both my daughters were very young at that time. My younger one was just, I think, 5 years or something. And I was wondering, who will look after my kids? How will I, help them in their studies? Will we be able to sleep together? Will we be able to share our meals? Can I kiss them? Can I hug them? See, we all know tuberculosis is curable. You're perfectly fine and you start medicine and I mean everything is so very normal about tuberculosis. But when it happens to us, that's where we realize that how drastically it can affect your mental health. Thankfully, after 3-4 days, when I went for the second X-ray, the shadow was clear, pain also had subsided. So most likely it must have been some infection in the lower respiratory tract. But then just imagine if something like this can disturb us. So death or complication or deterioration or some serious illness or majorly actually they can affect anybody's mental health, emotional health, and how they handle the situation. So I think today's session, I want to discuss from a couple of perspectives. One is uh, how do you feel when you are on the receiving side? We need to understand that perspective because we are comfortable telling people you are diabetic, you are hypertensive, you have arthritis, you have migraine, or you have gastric ulcer, or it is ulcerative colitis. I mean, whatnot, we kind of distribute like chocolates to patients. But what do you feel when you are at the receiving end? I think it's important to understand that. Second thing I want to also highlight here is it's not an easy task. So when we expect our doctors to do the breaking of bad news in a very meticulous manner, honestly, it's not that straightforward because you never know what is going to happen next, how the patient is going to react, how the family is going to react, and what other factors can influence the total discussion and where it might go. And we all know a lot of time, I mean, breaking bad news actually leads to violent reaction from the patient. We have seen this in a lot of situations. So I think that perspective also, I think we need to discuss besides other things. And also, we know breaking of bad news has to be done by the treating doctor because that's what is the expected role. But then, what is the role of other professionals who are around, who are in this situation? So, how should they be handling it or, participating in this, and how they can see that they can, at least not complicate the situation? And some deeper understanding of what exactly happens in the person's mind. The person who is receiving it will try to understand that part also, because we all react differently to these kind of situations. But then, more or less, I think the cognitive process is quite similar. How we receive the news and how we process and then react to it. And then, how can we proactively plan to handle those situations in a very mindful manner? Because as of now, it's more like reactionary kind of a way we handle breaking bad news. We announce, and if the family suddenly starts blaming us for negligence or for some kind of, not enough being done for the patient, we suddenly feel on defense and then we start reacting to it and start arguing or we start explaining. That further aggregates and then at times that leads to. So the whole discussion is about various, perspectives and aspects. And I want each one of you to think deeply about what exactly is the situation and then how do we handle it? How do we manage it? How do we prepare ourselves so that we can actually do this job in a more professional and responsible manner and mitigating this situation. And I think this is one training that should be done for all doctors and all other healthcare professionals also. As I said, breaking of bad news is done mostly by the doctors because they are authorized to discuss patient's status, medical condition. But then everybody has a role to play, right? From the security guard to the general duty attendants and the nursing staff and everybody, they have a role to play. So this is something I think everybody should know how do you really behave and act in such. So going further, I think I want to know from you, have you witnessed any breaking of bad news or something that was done poorly and that really kind of uh, affected the patient or family? Can you recollect any incident where it wasn't done in a very proper manner and it led to kind of unexpected outcome or reaction? If anybody wants to share their experience. Yes.
Ma'am, basically, breaking the bad news, it has to be done by the senior most faculty or the person who had seen the patient throughout throughout the course of that patient in the hospital. When sometimes class 4 ward boy or some guard, the patient used to ask everyone, so
Mm.
how is my patient? If someone have told them, no, your patient kidney is not working, yes, just layman terms, then it may create a problem.
I think wonderful. You have brought another perspective where we need to actually, alert our staff not to lose talk with the patient's family, because it has to go in a proper manner by proper preparation, discussion, and then you help them understand what exactly is the situation. But a lot of time, you're very right. Somebody from the board or department would go and talk to the patient's family and talk, sometimes even ill, poorly. Surgery hasn't gone well. Your patient is deteriorating, or there's a lot of blood loss. Something like this. I mean, even a simple case can get complicated if you don't talk. And I agree with you. So that means they also need to be trained not to go and talk loose with the patient. I agree. That's another important point. Michelle, you wanted to add something. Go ahead.
Yeah, so I think during my early days when I was training in psycho-oncology, we were posted in various wards in the regional cancer center I was working at. And many a times at that point, and this was in 2011, patients would come in and they would say, you have stage 4 disease. They will, I mean, most of the patients who would come from rural backgrounds, they would come with fungating wounds and masks that, even they are petrified to have on their bodies, right? So they would just say, it's stage 4, we can't do anything, go home. And I mean, so then in their mind, you can see that they're so confused or they're so shocked. What is stage 4? What is nothing can be done? I came all the way traveling so many kilometers. And then you say, go back home. What am I going to do at home? And they'll say, okay, you know what? We'll talk to your relatives and we'll push the patient out. I remember having so many, I couldn't say arguments, but so many conversations with the residents, the senior professionals at that point saying, are we saying we can't do anything? Right? Is it at least in the manner at which we are going to say this? Is there something that we can do? And because it is so routine, like I don't blame the doctor at all, because he was seeing like 60 patients a day, of which easily 30 patients is almost half is giving bad news. Right? Either it's a cancer diagnosis or it's in stage 4 and it's not going to. So I mean, my heart definitely goes out to them. But I realized at that point that our role becomes more as people handling the fallout of that breaking bad news, and not so much. That was not our role to give the bad news, but to handle what comes after it. So, yeah, till date, I've obviously been part of so many conversations with my colleagues when breaking bad news happens. But yeah, I think the other thing is our nonverbals. And more than what we say, I feel like the way it is said and how we look and react, and even that blank expression almost conveys like you're just another person who I have to tell this to. So, yeah.
Agree. Quite painful to hear. I know. There's a term called emotional exhaustion. So maybe people who are doing it every day, they completely, I don't want to say insensitive, but somewhere there is exhaustion and then you are fed up with that situation. I think. Anybody else who would like to share their experience of something they have witnessed? So I remember in one of the situations, a lady delivered it was a case of intrauterine death. So she delivered a stillbirth. And immediately after delivering, she went into amniotic fluid embolism. So she had to be moved to the bigger center. She was immediately moved. Nobody knows whether she had already died here, but the hospital moved the patient because they didn't want to, they wanted to buy time probably, and that's why they moved the patient from there to the next center. So the dead body of the baby fetus was with them. Somebody from the hospital, this smaller setup, calls the patient's family to tell them कि देखिए वो बच्चे की body ले जाइए because there are cats and rats around and we don't want any harm to be done to the body. Imagine, I mean, you can well imagine what must have been the reaction of the people, how they must have felt. And this call was not from the doctor. I'm sure she wouldn't have called. Must have been by one of the nurses or the attendants. Must have been nurses because usually they would do the. So, Mitu, we are discussing breaking of bad news, and we are in the preliminary discussion. I think you were over here in the
So it's
discussion.
raining very bad outside. So I just reached.
Yeah, I can see you're still quite wet. Even here it was raining very, very heavily. So we are discussing what the breaking of bad news and different aspect of it. And I was just sharing one incident where this is how the hospital staff communicated with the family of the patient. And unfortunately, both the baby and the mother died. Because I don't think in a aortic fluid embolism there's any possibility of revival. It was just that probably they were buying time to communicate the bad news to the family. But that's because we don't know how to handle such sensitive conversation. So, Michelle, if you say they are seeing 60 patients and out of that 30 patients are mostly either in the last stage of cancer or they already have metastases or whatever, I think that does not give me the excuse to be rude and non-sensitive. But it is still understandable. But we see it, where there is not much of workload. Everything is okay, but we don't know how to go about it. So there is definitely need for a lot of training in breaking of that. That's one understanding we should definitely have. Vidu, do you want to add something to the discussion?
So I think empathy, like what I've seen is like if you're empathetic to a situation, definitely breaking of that news would be in a much better state and shape. Usually, when we say like the doctors are busy because I've been into it, but I've seen some doctors doing very, very religiously and nicely the communication if they have to break a bad thing. So for us, it was very like किसी को HIV का report भी बताना है positive. So it has to be in a very logical way. So just can't be like you are positive. So to build up the whole story and then slightly you tell like how you. So that's where I've seen a lot of people doing it nicely when they start feeling it, that how is it going to be. Otherwise, there's some they'll just say कि आपका relative था वो it's over.
Yeah, absolutely. I So we'll do a small practice session. The whole idea is that I want all of us to be into each other's shoes. So what I'll do, I'm going to create 3 breakout rooms and put 2 of you in each one. So one of you has to act as a doctor. I know not all of you are doctors, but then just try to get into that role. As I said, that it's important to generate empathy even for doctors, but it's not easy. So I want one of you to play the role of doctor and the other one the patient. And the situation is that your patient is a young man or woman, and he's a case of pancreatic cancer, CA pancreas. So you have to do the discussion, break the bad news. It's a confirmed case. You have done all investigations and it's a confirmed. There's no doubt about it, but you have to now announce it to the family. Is that okay for everyone? Are you comfortable? So between you, you can choose who wants to be the patient and who would be the doctor who would be doing the announcement. Is that okay? So I'll try putting 3 of you separately, Michelle, because you have done, at least you have witnessed a lot of breaking of bad news. Dr. Pradeep, I'm sure you also must be doing a lot of it. And Dr. Miku, you have witnessed it. So I'll put three of you in that. Try to be the patient rather than being the doctor, because you are doing it already. So I want three of you to experience the other side. And Ashia, Maheshwari, and Shika, I want you to be the doctors who are going to break the bad news. Is that okay? Ready for it? Maheshwari, any question?
I mean, we will not be knowing the symptoms now, ma'am.
Mm.
How, as a doctor, we need to explain them, like, because of all this, because I'm not much aware of.
I understand. I get your point. So maybe then it's okay. You choose between you how you want to do the play. Is that okay? Okay. Let me create the breakout room.
Is it going to be a two-way communication? Like from the patient side, is he going to ask the query like, how is my patient doing?
Yeah, try to get into the patient's character
Okay.
and act like a character. I mean, patients. Only then you will get to sense what doubts the patient will have, what questions the patient will have, what will be the patient's apprehension. You have to think like the patient that yes, this is what I've been told now. Like I shared my experience that I was just told that it's very tuberculosis. So how I felt, I mean, I shared with all of you. The same way when you will try to get into that role, you will realize how the patient thinks or reacts to this. That's the whole idea. So I'm creating the breakout room and all of you are requested to join the and 3 to 5 minutes, maximum 5 minutes. Yeah. So both of you were in the same breakout room, I think.
Yeah.
Dr. Neetu and Dr. Deep, yes. But could you do the role play?
Ma'am, we did role play there.
Mhm. You did it.
Yeah.
So let everybody come in and then we hold the discussion.
Okay.
So normally it takes 60 seconds. It gives a time for 60 seconds to wind up. Okay, so could everybody do the role play? Any
Yes.
group who could not? So Maheshwari, who was with you?
Harshia, ma'am.
Okay. So Arshia, could you do the breaking of bad news for Maheshwari?
we actually, we actually could not do it that well.
You
We,
could.
yeah, we could not. So we
Uh,
discussed it on how the bad news is normally broken because we both are non-doctors. So we discussed how it, I discussed with her, how the experience was when it was broken in my family for, my father-in-law and how the effect was. So we discussed that.
We shared that experience. Even that's good. If you could talk about something that you have personally witnessed, so that's also a good sharing of your experience. So, and Michelle and Shikha, how did that go?
Yeah,
Who
so
did?
we did little bit of role reversal. I was patient and Shika decided to be the
Okay.
physician.
Okay. So, in your case, Dr. Pradeep and Dr. Mitu, who played the role of the patient?
I have played the role of the doctor, rather patient.
And Mitu was the patient.
Yes, ma'am.
Okay. So, first of all, I want to ask who played the role of the patient? What did it feel to be in that role, in that character? Patient, whoever was acting as a patient.
Lot of questions, lot of uncertainty. Uh, just expecting one thing from the doctor कि एक बार बोलते सब ठीक है.
Mm.
So that uncertainty actually kills you because when the doctor is talking, वो बहुत धीरे धीरे they try and explain again, and you're like, what next? So
Mm.
that weight in the mind boggles you. I just could. यहाँ तो मुझे पता था कि यही बोलेंगे कुछ time में. But then
Mm.
I'm just thinking, it's like even the MRI report or something,
Mm.
you're waiting for that result. It's like an exam.
Yeah, you're waiting for the result. Absolutely, I agree. Thank you, Neetu, for sharing that. So, Michelle, you were
Yeah.
patient in this role play.
Sorry, this power outage.
No.
So yeah, so typically what I was experiencing was like shock.
Mhm.
I couldn't believe it. Like I kept asking, "Are you sure it's my reports? Are you sure it's CA pancreas? Like how can I get it? I'm so young."
Mm.
And I think this is most of the time I felt like I couldn't hear much of what Shika was saying, other than she's telling me that we are here for you, we'll be there for support. But
Mm.
in terms of what's running in my head is like, what? Like how Dr. Mitu was saying, right? Like that's all there is, like that shock reaction. And I think nothing else is penetrating, right? Like even though I know she said there's going to be treatment and we'll just wait for your husband to come in to give you more details and all of that. I was in my mind, I could just hear like how could this happen? Like what happened? Like just ringing back and forth.
So, see, although it's a role play and it is difficult to bring in those intense emotions because you know it's a role play, so you can't. But just the thought of it is so scary. Imagine what people go through and then how they handle it. Of course, everybody gets the courage to manage the situation ultimately. But then when it comes as a shock. Then slowly people get used to it and they start learning how to readjust their life to uh, handle that situation. So those who were playing the role of the clinician who was breaking the barrier, like the or Shika, uh, what was your experience being in that? What
was
were your
very
concerns?
difficult. It was very difficult how to start with.
Mm.
I mean, how to make the patient calm,
Mm.
relax,
Mm.
then what to say first.
How to start?
Yes, that is the main issue. I felt this is a big issue in front of everyone,
Mm.
even in the family members also, if they know something. And
Mm.
mostly doctors didn't tell these things to the patient directly.
Mm.
They first tell these things and discuss these situations with the family members. Um, and it's very difficult for the family members to tell all the scenarios to the patient.
Mm.
And then so many questions from the patient side
Mm.
and the worries of the patient. What will happen after me? They will just think one thing, that what will happen after me. They will not think about the treatment part.
So many things. See, it could be this, it could be like what will happen to my family,
Yes.
or how will things move on. I'm the one
They
who is.
will never ask that whether I will be okay or not. They will think that what will happen to my family after me.
So, Dr. Pradeep, if I may ask you, uh, I'm sure you must be doing this since you are intensivist and you must be working with patients, so you must be making this breaking of bad news often. How does it feel to be there?
And definitely not good.
Right.
But but what I want to say, the whole exercise starts from the day one.
Mm.
We have to develop the rapport with the patient relatives from the day one. So we have to tell them what are the possible complications they may arise, even 5 to 10%, and then build up the rapport with them so that we can break this bad news later on. And
Then,
what I used to do, I used to write the name of the patient relatives in my noting
mm,
every day, with
mm,
whom I have counseled them. And but definitely it's a very difficult. And once we have the word empathy means that putting into their shoes. So that's not easy. So you have to be very calm. Um, they must understand, and we have the breaking the bad news protocol says 3P. Uh, uh, that is the place, person, and the physician.
discussing it.
So.
Pradeep, that will be discussing. What I wanted to understand from you, see, one is you highlighted a very important point. This time when I went to Patna to do doctors mentoring program, I introduced two topics for them for the master trainer program because they were purely doctors. So they had to be trained to train the doctors at district hospital. So one was power of shared decision making. We normally don't do shared decision making. We decide on the patient's behalf. That's what puts us into trouble because if we are not engaging them right from the beginning in decision making, they feel that they have not been told, they have not been informed, their consent has not been taken. So they are not sure what is going to be the outcome. And then second topic I introduced was prognostication. Why prognosticate, how prognosticate, how it is going to benefit, how it is going to help you in counseling. And also, we also would be knowing what is the likely outcome if we have done a scientific prognostication. We also would be knowing what is the likelihood of the patient making out or patient really doing well. So these two topics have covered, and I think you have brought in the same thing that if you start the assessment right in the beginning, and you keep the family in the loop and let them know that this is the situation and this is the direction most likely we are going to move into, either bad or good, so that right from the beginning they know what they can expect as an outcome. I think, and this every doctor needs to be trained to do this right from day one. We have really brought, we'll be discussing these points in a while. So what questions were on your mind when you were doing the breaking of bad news with your patient?
Ma'am, basically, yeah, ma'am, what are their what are their queries, whether they can afford the treatment or not. It also comes to my mind. So if they cannot afford the treatment, I simply say it will take time. It will take 5 to 7 days of ICU, and if the patient goes on ventilator, the cost will be that you can check from the TPA desk or from the reception desk. Or now at this stage we can transfer this patient to the government hospitals. वहां पर भी अच्छे से इलाज होता है अगर कोई फाइनेंशियल इश्यूज हैं. So these things have to be cleared. And for prognosticating, ma'am, we people follow Apache and SOFA score on the day one. So Apache, basically these are the technical terms. इसमें it depends upon the total physiology parameters of the human being. So we can prognosticate that this much percentage of mortality can happen to the patients. So from the day one, we can tell them there is a risk of mortality of 20%, 30%.
Very nice. Yeah. Yeah. Some kind of scoring, scientific scoring to
Yes, ma'am.
So when you are, like you said, when you are breaking the bad news, these are your concerns, whether they will be able to understand, whether they will be able to follow. Is there also a concern that what if they don't trust me, or what if they think that I have not looked after the patient well, or I have failed in my care or responsibility? Is that concern?
Sure, ma'am. But if you're from the day one, you are having a good communication with your patients. You are giving them at least 5 to 10 minutes, minimum 10 minutes for the counseling. It happens with I had seen basically it's a teamwork. So I had seen the physician, surgeon, so who didn't give much time to the patients. They usually have the problem with them कि उन्होंने मुझे कुछ बताया ही नहीं, मुझे कुछ समझाया ही नहीं, वो कौन से डॉक्टर साहब थे. So their
Very right.
conflicts occur.
Again, you have brought in a very important point. If you're regularly updating them and if you're investing those 5 to 10 minutes with the patient's family, that really saves you at the end in case if things go wrong. Then they don't blame you for being, irresponsible or not concerned or insensitive to their situation. That's a very important investment. So I was interacting with the CMO of the hospital, very premium hospital. So I said, how many times have you experienced violence against you? Especially you are in casualty, you are in emergency department. He said, not even once. I said, how can that happen? He said, the moment we receive any patient, for example, if it's a road traffic accident or some major injury, and we know the patient is in serious condition, on one side, my team is, settling the patient, and on the other side, I start talking to the patient's family. And I start helping them understand that this is the situation, this is what we can, expect, and we are doing our best. So step by step, actually, we need to first of all update them that what is being done in the patient care, what all we have done. Because if we are doing everything and we are not informing the family, that also they can't see because they are not in front of the patient, so they are not able to see what is being done in the patient care. Mostly they are outside, so they feel that patient has not been attended or have not received, immediate care or attention. That's where they accuse us of negligence and being, late in handling this. So he said, I normally communicate with the family instantly and then I keep them updated. And frequently I inform them about the status so that they know where we stand. And you are very right. If we are updating them, then they are mentally prepared for something like this. Then it doesn't come as a shock. It doesn't come as a shock. So, what do patients expect when we are breaking bad news? Generally, what do patients expect? I mean, all of us have seen something like this in our personal life, or you must have seen patients, under your care. What do they value? What do they expect?
Basically, they expect good outcome of the patient, whether that can happen there in that setup, or can we refer डॉक्टर साहब हम इस पेशेंट को कहीं और लेके चले जाएं, वहां ठीक हो सकता है. So we had to give them very fair opinion. So we usually give them a summary also, so you can have a second opinion or you can go to any other hospitals. So
That's true. So, Michelle, like you were handling similar cases like with cancer. So when it comes to sharing of information, how many of them are really wanting to know about their condition? Or do they say, talk to my family, don't tell me, I can't handle it? What is the usual? Uh,
Yes, recently we've done a study in the hospice and we found actually 50% um, don't know and 50% know. And out of the ones who don't know, they actually want to know. It's just that their family is either in collusion or don't want them to know about it, fearing that there's going to be a very negative consequence to the fallout of hearing the information.
Mm.
So I think culturally also it's a lot to do with decision makers
Mm.
and relationships, right? We've seen that if there are male decision makers and the women are the patients, then everything is kind of like rationed out. Oh no, they might not take it, they'll get very irritable, this, that, and the other. And very rarely do we see them having attenders. But in our male wards, you have all the wives or the sisters or the children accompanying them, staying there, and they most of them have attenders. So when we go into actually breaking bad news, they have some bit of support.
mm,
So I feel like people want to know. And for us, we have a kind of a decision making which we do within the team, whether based on the prognostication, whether it is worthwhile telling this person.
mm,
If I know somebody's actively going into end of life in the next couple of hours or days, how is this information going to really change their worldview and the situation that they're in? Because they might become drowsy, non-responsive, and many a times they're in either too much of symptoms, so we need to handle those things as well. So we struggle with that. I mean, it's tough. Ideally, we'd love to tell everybody, and ideally we should, but we don't have any laws that tell us that we have to say it as against how it's
how
abroad.
do you handle the family's request that we don't want to tell the patient, so you don't tell?
Yeah, so typically when we see that happening, again, like I said, depending on the prognostication, like in terms of time or
Mm.
approximate survival, we sit and first talk to the family members and try and understand reasons for why they don't want to tell.
Mm.
And many a times it is this that, you know, they have to handle the fallout of the news and the person will stop taking medication. They'll say they want to go home
Mm.
and all of that. So many a times they think when we say we want to break the news that we're going to go there and just say it.
Mm.
They forget that it's a process, right? We will, you know, step by step ask them
But
and
once they say that we don't want to tell, how do you help them understand that why should we be in
not.
some situation?
Yeah, so we talk about what happens to the person, their autonomy, their inability, and especially when they start deteriorating, they have a lot of existential crisis and questions. And we also talk about saying that we are here for support because most of the time they fear that the caregivers have to be the ones making these decisions and telling the news.
Yeah.
So I mean, there are obviously families which agree, but we also have had situations. We have a pediatric patient right now, a 13-year-old who's unaware of his prognostication, and he's got like a couple of days given his symptoms. And the mother was when they got admitted last week, she's like, please tell him he's dying. I can't bring myself to do it. And we are complete strangers to him with pediatrics. It's a whole other ball game. So
She's saying tell him. She wants
yeah, she said, you know, I can't bear, you know, not knowing that he's dying because he thinks that I'm forcefully putting him in an institution. He wants to go home. So over the course of time, we've managed to break it in bits and pieces to him, which has kind of brought down his frustration about saying he wants to go home, but he's become extremely he's going into that kind of terminal agitation phase. So he's more or less sedated at this point. So, and there's a lot of dysfunction as well. So
anybody
it is
wants
very
to
hard.
add to what Michelle is saying, your own experience, your own observation? Mitu, Arshia, Maheshwari, Rekha, anybody wants to? Because I know this is a very typical situation. She's only handling, onco patients, so naturally she must be, but others can always pitch in and ask also in case because I normally say that when families say that we don't want to tell the patient, they normally underestimate an individual's power to handle the crisis. Usually, you will see uh, once they get to know, they of course are disturbed, but then they gather their courage and they try to see how they are going to, But at the same time, I want to remind the family that we have to remember that we put a lot of things on hold, thinking that I will do this before I die. I want to do this before I die. I want to apologize. I want to write my will, or I want to talk to that person. I want to clarify something. So, I mean, we are just uh, depriving the person of those opportunities where the person can live peacefully. And also, the family, I think, remains under some kind of not guilt, but then there's a feeling that I should have informed the patient. I should have let the patient know. I think this is what is my because even when, as I think I mentioned to you, that I work with a lot of adoption cases for quite some time. I was working with an adoption center, so there normally parents will say, "No, we don't want to tell the child." But when you help them understand that ultimately child will get to know, but how the child will get to know will decide how the child will be affected. So better and earlier the child gets to know, better it will be for you and for the child. So same way, I think we need to talk to the family and help them see that this is how they have to let the patient know. But of course, it has to be done in a very, very sensitive manner. Normally, sometimes we become very rude or blunt in our. Any questions? Anything somebody wants to add? Shikha, if you have something to say or ask.
I just think, ma'am, it's like it's the right of the patient to know his condition. A typical case, the one you say, like you just feel like I have to do everything. So limited time, but you want to clear that. The other is also the support from the family at that point is must, because they should not go into kind of a sorrow phase.
Yeah,
And that's how I think the communication with them and everything needs to be translated.
yeah. Peacefully, everything should ultimately end to peace for both
Yeah,
people.
yeah. A typical case, what we saw in Munna Bhai MBBS. So there's one who's about to die, and then they arrange everything for him. So they wanted him to live that life, what he couldn't live that. So
Absolutely.
And I
So I
also
know
had
our
to add,
yeah, yeah.
sorry, I also had to add in terms of like processing time, right? Like everybody processes the information so differently, especially medical information or any critical news. So many a times, or at least something that we've noticed is once you've given the news, like there's the saying that you'll always be a part of their lives,
Mm.
right? So a lot of it depends on how that news is given. Like they will always remember that this person told me this
And
news, right? So if you are on the receiving end, the next day when you go to meet them, you can't be going there saying, "Hey, so how are things? What is happening?" Because you just told them such difficult news the previous day. So allowing them to feel like they want to sulk or they feel upset or sad is something that I feel we are very uncomfortable with. So many of the times we've seen like people be like, it's okay, we told you, no, we're all here, we'll get things going, we'll manage your pain. And you're like overcompensating when actually they just want to feel hurt and they want to be hurting. So I think that emotional time we rarely give for people to process.
absolutely. Also, in our country, I think the rights of the patient are very, not really very demarcated. Though they are in black and white, but how many of us really respect them or consider them? And we always look at it from the family's perspective because family should be, comfortable or okay with it, and then we don't care much for the patient's right. Honestly, and patients are also not very vocal about their rights in our country, and therefore, they will not kind of actually fight with you that why did you tell this to my family and why did you not talk to me and why did because they're also okay with the idea that it's okay, it's the family who is looking after me, so they have all the right to the information. So the margins are very kind of not very well defined, and they're quite diffused. So therefore, there is not a. But yes, we at least should explore. We should at least find out from the patient, whom do you want me to talk about your results, or would you like to know, or would you want me to talk to your family? So a lot of time when we do this, at least we are giving them an option to say yes or no. And if they don't want, then probably, but of course, a lot of time HIV patient says that don't tell to my wife, don't tell to my, there of course you have to use your discretion and you have to inform the partner because you don't want them to get affected. Okay. So let me share the presentation that I have prepared on this and take the discussion further. If you have any questions, we can definitely take it here. Or maybe even while we are discussing, we can have. Yeah. So let me share the screen with all of you. Okay, so we have done the role play. We have discussed the role play. Okay. So these are the questions I wanted to ask for the persons who were breaking the bad news. That how did it feel to be there, and what questions you will usually have on your mind, and the challenges that the what challenges do you think the clinician will have from your guests, like those who are clinicians? Dr. Deep can share his thoughts on it, but others, what do you think could be the challenges the clinician will have when it comes to breaking of bad news?
Time,
Time can be a challenge. Okay.
the particular setting they're in.
If there is no proper setup, a lot of
Yeah,
time
there's-
we do it in the corridor or bedside or ICU where others are also overhearing your discussion. Agreed, that can be also a challenge.
And our own, you feel not confident about.
You're not sure of
Sure.
the way to handle that, how to deliver that. Vocabulary can be a challenge. Language can be a challenge. Patience can be a challenge, especially you
Family
feel that
members.
I might be blamed for the
Mhm.
poor outcome. So, how do I handle that situation? Some people are very incompetent at handling emotions. They become aggressive when the patient party starts crying or kind of, reacting emotionally. They feel uncomfortable. They are not able to handle. And what are their usual concerns? Anybody else? Somebody wants to answer? What are their usual concerns?
What if the patient get aggressive or the patient family member get aggressive?
Definitely. That's one thing. What more? What do others say? How will they react?
Don't you think it can be like, am I the right person to break? Should the primary consultant be talking about? Should the administrator?
A lot of time, actually, seniors would leave it to the juniors to do the breaking of bad news. So it causes a lot of dilemma to the juniors that it's the consultant who has been looking after the patient, it's the consultant who has been handling the case. They are the one who should be doing the breaking of bad news. But we all know a lot of time the responsibility is left to the juniors. So that also can be, quite disturbing for the person who is doing it. Also, what if the family blames them for the outcome, or they become aggressive, or they start fighting? So, how will I handle that? Will I be able to handle something? So these all could be.
Sometimes it's always like, agar media mein aa gaya, so my name is going to come. So that concerns also come up.
Yeah, absolutely. So when we talk about the patient's perspective, I think, as Michelle was telling, and even a lot of studies have shown that patients actually, want to know about their disease condition, but they want to be communicated clearly and empathetically. So they want to be involved in the decision making. They want to be told what it is like, what is the likely outcome, what can they expect in future. They probably require time, as Michelle was talking about the processing part. So when they discuss, it's not easy to immediately process and accept what it is, but they require time and they want to have thorough discussion about it. And a lot of time when we do it in a hurried manner or in a casual manner, or we show that we are very busy or we have some work, it really, really upsets the patient and the family. So, I mean, that's what probably the families want, that we give them time and opportunity to discuss. As I said earlier also, breaking of bad news is one of the trickiest and most difficult communication, especially when we are going to discuss something like death, poor prognosis, complication, or unexpected outcome. You can expect, aggressive reactions because some people are not able to take the news and they react abruptly to it. You must have seen a lot of violence also, coming out as a reaction to the situation. And especially when a younger generation doctor is handling it, they experience more challenge because one really requires, advanced level of communication skills, a lot of patience, composure, tone of voice, selection of words, body language, then experience in handling emotions. So that comes either with training or with learning by doing. So young doctors, if they haven't had any training, they are the one who experience, challenge in handling situation like this, unless they really, really work on the way they are going to do it or how they're going to handle the emotions and the questions that are going to come from the patient side. And more than that, I think they also have to learn to handle their own emotions at the same time because there's a lot of emotional and inner conversation that goes on, and that would be kind of acting as a noise inside. That's what they really need to learn and practice to handle that. A word of advice that I normally give to everyone is that please develop good rapport with every patient because you never know which case might turn into an emergency or have an unanticipated outcome. See, a lot of time what happens, that the prognosis is poor. But in number of situations we have seen, it could be just, a drug reaction and the patient collapses. Or a procedure going wrong, a simple procedure going wrong. I remember I'd seen one patient undergoing lumbar puncture and then instantly the patient collapsed. So there, everything appeared normal. It was an OPD procedure. Rather, it was an indoor, but in the side room, the doctor was doing the NP for CSM, and the patient collapsed. So if you have rapport, if they know you, if they know that you are a responsible doctor, you wouldn't do anything carelessly, they would still kind of accept it. But if we haven't developed any rapport, if they have no idea about the kind of person we are, that's where the risk of allegation of negligence comes in. So creating familiarity actually reduces the risk of aggressive reactions. Studies have shown that patients and their family members are less likely to be aggressive if they know the doctor, if they're familiar with the doctor. So creating familiarity actually goes into our favor, and one should make an effort to know the patient's immediate family member by name. Actually, by keeping them in the loop is the best way to create familiarity. So make sure that you regularly update the family, talk to them, address their concerns. Whatever questions they have to be answered with patience and with clarity and honesty. And then, of course, when it comes to decision making, for example, you are recommending put the patient on ventilator, or let's move the patient to the ICU, or let's do this procedure, or let's put the patient on chemotherapy or a surgical intervention. So all these things require, time, energy, and financial investment. If you are not involving them in decision making, and ultimately if the patient doesn't recover or things go wrong, they will normally accuse us that, oh, we did this just to make money. We put the patient on ventilator because we didn't want to lose the patient, or money, so we have put the patient on ventilator. And in all these situations, I think transparency and honesty goes a long way in winning the patient party's trust. So through and through, if you have been transparent and you have been honest in, answering their questions. I remember for my brother, his doctor wanted to put him on a ventilator. He had developed pneumonia and then a couple of other problems. So I just asked him very directly, what is the chances of recovery after We put him on ventilator. So he was very honest. He said 60 to 70% we will be able to get him back. He will come back. And the next time when the same situation happened, he was very honest in saying that there isn't much chance. It's only a matter of if we want to try. We just have 20 to 30% hope. So he was very honest in both these situations. Although we put him on ventilator, but we knew with clarity that the chances of recovery are very, very low. But we want to still take chance that maybe it works for him if he comes back. So again, although we fear that the patient party might say, okay, let us take the patient back if the chances of recovery are poor, it's better if they want to take back it. Why not? Why should we insist on admitting the patient if we know the chances of recovery are very poor? So when we have this approach, they can sense it, and they also have trust that we are not kind of fooling them. Another thing that I want to bring in here is that let's understand one thing. When the patient is in critical condition or has a serious diagnosis, the family is constantly looming under the greatest fear. And that greatest fear is fear of death. And anybody who is under this fear, their state of mind is not normal. Don't expect them to react in very normal, wise, and composed manner. They will be agitated, they will be upset, they will be aggressive, they will be irritated, they will be feeling down and low and doubtful and questioning. But studies suggest that we look after the patient very well. But when it comes to addressing the family's concerns, we don't consider the family as the beneficiary of it. I think one thing that we have to remember is that when the patient is in critical condition, it is the family who is the decision maker. They decide on the family's behalf, patient's behalf, and they are the one actually who are even paying for the treatment, honestly. Running from pillar to post to arrange medication, to arrange other things, and they are the one who are constantly around the patient. So addressing their emotional needs and involving them in decision making and patient care are the ways to meet their needs and kind of prepare them for the outcome. Because you don't know if there's all possibility of the patient going, then it is better that we, kind of even bring that up in our list. So I'm going to share a protocol with all of you, the one which Dr. Pradeep was talking about, 4Ps. I'm sure many of you must have heard. There are a number of protocols available. This one I find simple and easy to comprehend, so I'm sharing this one, but there are many more protocols. So these protocols are more like guidelines to help us learn how to go about doing it. So like mentioned by Dr. Pradeep and some of you others also, that breaking of bad news should be done always by the senior most person, the person who has been managing the case till now. He or she would know in detail about the condition, what has been done, what tests have been done, with what intention you did those tests, whatever treatment intervention you have made, with what expectation, with what discussion. So all that, I'm sure the person who has been, in charge of the patient would be knowing in detail. So he or she should be actually doing the breaking of bad news. So there are 4Ps. The first P is about preparation, where you actually prepare yourself before you go and start the discussion. You choose the place and you also prepare the patient before you start the discussion. So it could be the patient or patient's family member. The second P is about performance. How do you go about doing it? Like Shikha was saying, it is very difficult to start. We don't know where to start, how to start, what to say in the technique. So we'll discuss briefly about how do you go about doing it. And then third P is palliate. We are given the news, now it is to help them, kind of absorb it and also see what options they have. And then of course plan, where you kind of plan about the options available and then choose what is going to, work in the patient. So as I said, the first P is about preparation and preparation of the physician. So it's very important to actually know in detail about what you are going to talk about. So I have seen people going, to break the bad news without exactly knowing what investigations we have done, or what treatment options we have already tried, and what has been the outcome. The report of the test they may not know. So it's very important to be very, very sure what all has been done till now, why it was done, what other options we are left with, or what has been the report or the response to the treatment. So before you break the bad news, making connection with the person is very important. Of course, I think we would be knowing the patient and the family member by now. But there could be some more people who have just joined in. It could be the elder brother or a relative who has come from a far off place, but that person is with them. So naturally, you need to get familiar with that person, make connection with them, so that you become comfortable, talking with them. Uh, be mentally ready to spend some time. Anybody who tries to do it in any kind of hurry, you're calling for a problem. Because if you seem to be in hurry, it immediately gives them a feeling that you are not taking it seriously, or you're not really, very uh, affected by it, or you don't care, you're doing it more like a duty. So make sure that you have enough time at hand, and please avoid all kind of interruptions like phone calls or visitors or a patient waiting, or there's a call in between, or somebody wants to meet you. So all those kind of interruptions should be put on hold when you are doing this, because it has to be with complete concentration and focus on the issue. I'm repeating, it should not be delegated. It should be always done by the person who is treating the patient, who has seen the patient through and through, who is thoroughly knowing about what has been done in the patient here. Now, coming to the place, where all do we do it normally? Where all have you seen this being done? If I know your hospital, where do your doctors break the bad news or discuss with the family?
There is a room outside, mostly outside ICUs, where they do counseling part and they meet the patient and patient family members. So there they do the break this news to the family members.
But if it is not an ICU case, if it is a non-ICU case, then
Outside the wards only.
do
And
you?
there are other people also around.
There are people. I know, especially in government setup, we see, doctors doing this discussion with the family, maybe outside OT, outside labor room, outside ICU, corridor, in the OPD, with sometimes other patients and their relatives overhearing the conversation. All this is something like calling for a problem. It should always be done in a separate place where you can sit down and talk, because it will require some time. And when you stand and talk, it adds to your exhaustion and mental stress. It's better to sit and do the talking. So wherever possible, please make sure that you create some place where you can sit and do the talking with the patient. Of course, make sure that others are not overhearing your discussion, because a lot of time others would interfere and complicate the situation. They will instigate, they will talk ill, they may add to the situation. And then if you are able to involve people like psychologists or social worker or a senior nurse from your side, even your doctor, one of the doctors can also be part of the discussion. And from their side, it's always good to involve somebody who is older in age, who seems to be more calm and understanding. Because there will be moments when emotions will be high. The patient party might suddenly react. So there has to be somebody who can calm them down and kind of handle the situation. So if things like facial tissue, glass of water can be kept handy, that also helps, because a lot of time somebody starts crying, but neither they have hanky nor a tissue. So they are looking for something to wipe their tears or clear their nose. So if you have tissue paper or a glass of water to offer, that shows that you know the sensitivity of the situation. So, Michelle, in your place, do you Are you part of the team when they are doing the breaking of bad news? Are you there with them?
Yeah, so it depends if I need to be there. Others, my counselors are usually there, and it's always a planned activity. So we either soundboard the family that we'd like them to be there, or even we tell the patient we'll finish rounds and come back and we'll just sit and have a chat. So there's some warning shot and there is some space that is made.
Time must be kind of it.
Yeah, kind of.
That must be for the indoor patient. But what about the OPD patient?
OPD also the same thing happens that after the physical symptoms are examined, then we speak first to the family members, and then once we get a sense of what is really happening and how much they know, it's only after that we go into having a chat with them.
Dr. Pradeep, in your setup, how do you go about doing it?
We usually take the bad news with other colleagues sitting there.
Somebody around.
Usually a physician in charge, intensivist, or physician or surgeon.
They are
Pardon
the
me?
treating team? They are the part of treating team, or they are just there to,
No. Part of the treating team.
but you have a separate room.
Yes, ma'am.
Dr. Maheshwari, in your setup, sorry.
No, I was just wanting to add that sometimes we have, because it's a planned discussion, we even have the physiotherapist, the nurse in charge of the ward, also being part of the conversation, because if there are specific issues pertaining to wound care or medication or even physiotherapy, posture or position changing, lymphedema. So these are things that are also interest if there are questions that come because of it.
But they won't be doing the actual talking or breaking of bad news.
No, so the doctor is the person who does the breaking bad news. We are all part of kind of shielding or talking to them.
Okay. So, Dr. Maheshwari, I was asking you, what about your setup? How do you have a separate place? Do it?
Generally happens in OPD room only.
Unmute your device.
It generally happens in OPD only, ma'am. The doctor is going to be the primary person to break the news.
Okay. And do you have a separate place, or in the consultant room is quite private where they can
Yes,
do
it's
this?
very much private, and he'll be having other staff, supporting staffs for the doctor will be in the presence of the other staffs. Only the doctors usually reveal the news actually.
Okay.
And I haven't been a part of that. actually.
You're part of the team?
No, I haven't been there. If
Okay.
I haven't seen a doctor revealing a bad news to the patient.
Would you like to experience once being there?
Yeah, definitely.
It'll be nice for you to observe it, because now we are doing the discussion. So it's a very serious conversation that the doctor is supposed to have with the patient, and it should be done in a very meticulous manner, because ultimately you are handling a very important aspect of the patient's life. So it has to be done in a very sensitive and responsible manner. So I mean, you will get to see how well are they doing, and whatever changes, if you wish, you can recommend to them. Especially about place, like you're saying, there are people around, but are those people really, involved in the patient care, or are they really? They have to be around. That's something that you need to find.
Ma'am, but the very fact is, doctors usually try to escape. They just tell and walk around. And there are no such kind of team that support patient family members. They don't give such time ki they just relax and ask their questions. They just tell and walk away. That's why I wrote that there must be one team that, like you said, there are people around, but there are no people that actually involved. Like there must be some nursing or counselors or somebody other than doctor who can support, or might be administrator. Or being an administrator in my earlier hospital, I used to be there, but not always. Not every administrator is there in that team, because
Yeah, so
every
that
hospital doesn't have the counselors also.
there is no need to have too many people, because that also can overwhelm
No,
the
but
patient
there
and
must be few
compromise patients'
who
privacy.
can support the family members who can have a word after doctor finishes.
I think primarily it should be the doctor who does it, and maybe one or two people who are actually part of
One
the
or two
team.
only.
Yeah,
One or
but
two.
not too many people. Otherwise, it might tell the patient party that they have done something wrong, and that's why they're standing in number.
True. But
We
this
have to be
must be a
careful.
regular procedure for every hospital. That if you tries to do something like that, then you have to inform others and they come and be with you to support the family members.
Maybe one or two people who are actually
Maybe
involved in the patient care. I
Maybe.
think that should be. So, yeah, yeah.
A lot
So,
of time
Yeah,
involving people, they can have a different body language, which can actually, what I understand, they can, from the body language, a different message can be conveyed.
So,
So it's better a closed group.
I'll be talking about that part, what you have mentioned. That's very important because it's very important to be sure of how you are conducting yourself. Because and in those situations, non-verbal communication happens more than the verbal communication. And like Shikha was telling that they quickly, hurriedly say and they go away. That itself shows that they are not comfortable handling the situation. So they want to do it because they are the one who have to do it, but they are not mentally prepared and ready and know how to go about doing it. So therefore they kind of escape. So body language plays a very, very big role. We'll be talking about that part when we talk about performance part. We'll be talking about it. So when it comes to the preparation, we talked about the preparation of the physician. Then the place, like it should be done in a private place, preferably a counseling room, so that there's nobody who is overhearing your conversation. Patient might start crying, patient might start shouting. If it is done in a private room, emotions will go up and come down. But if it happens in a public place, then there can be it can go on and it can escalate to any level. So therefore, it should always be done in a flow. The third P is about preparation. And now in preparation, third P is about patient preparation. So it is very important to first of all know what does the patient know, from where do I start? Because if the patient has been referred by somebody, they have already got some investigation done, they have come to your setup, they already have an idea. Probably it will not be very difficult for you to, take the conversation further. That yes, even our reports confirm what your doctor has told you. But suppose if it is something that they have just no clue and they just come to you with some complaint, and after investigation you find out that this looks like this. So then probably you'll have to start very differently. So before you tell anything, it's very important. I'm sorry. It's very important to, check what do they know? What has their referring doctor told? Or do they have any idea about the test that you have done? So when you ask them that, why do you think we did this test? So if they have an idea, they'll say that probably you're trying to rule out this or that. So also, it's important to check how much does the patient want to know. A lot of time, the patient wants to know everything. That's what we understand. Patients usually want to know everything, but we assume that the patient would not want more information and they would want the family to actually know most of the details. So there is no harm asking, to the patient that we are doing this test and we will have to discuss the report of this test. uh, whom do you want us to talk to? Do you want us to come back to you, or you want us to talk to your family? So you get an idea like how much really they want to know. And then also make sure that you are able to assess how ready they are to receive the information. And if you think that they're not prepared, then it's better to reschedule it. For example, you did some test and the person has come back alone in the OPD for follow-up, and you have the report in your hand and it's clearly says it's tumor. Definitely, you would not talk about it when the patient is all alone. So you will first ask that who is with you? Have you brought your family member? Or make sure that you bring somebody with you in the next visit, because the patient may not be in position to handle on their own. And also, like I said, asking whom all do you want to engage in the discussion. Assuming, okay, in-laws would be more interested to know, or the parent party would be more interested to know. That assumption is not fair. Ask whom do you want to engage in the discussion so that you clearly know in whose presence you have to do the discussion. When it comes to how much do the patient wants to know, studies suggest most of the patients want to know as much as possible because they would have more clarity on the disease status and then how they have to handle in the time. Studies have also shown that when it comes to the gap between what the patient wants to know and what they receive is quite huge. For example, studies suggest that almost 57% of the patient wanted to discuss life expectancy because that's their usual case. Kitna time hai mere paas? How much time do I have? Only 27% actually could get the answer or discussion from their treating doctor. Then almost two-thirds of the patient wanted to discuss the effect of cancer on the other aspects of life, not just the medical intervention or the medical symptom, but how that is affecting their life. But we know very well that we are not very comfortable talking about the impact on their occupation or their personal life or their lifestyle, and therefore we don't really diverge or indulge into that kind of discussion. So again, studies suggest that only one-third of the patient actually got to discuss this with their doctor. Now coming to the patient's perceptions assessment, what does patient think of the illness? That's also very important. You will see a lot of time the patient will be in complete denial. No, I can't have this. Or they may have wishful thinking. No, I know somebody, they have this treatment in Ayurveda or they have this treatment in homeopathy, or they may have unrealistic expectation of the treatment. Please identify this and make sure that you address them appropriately. Because in case if you don't address those things here, later on they will blame you for misinformation. So address them, correct the misinformation, and then if you think they are not really ready and prepared for the news, you will have to tailor the bad news. Because if they are not completely ready, then probably you will have to give them, like Michelle was telling, that part in bits and pieces we kind of share the information with that child. So same way you will have to maybe stagger it to break the news. So this discussion when I was having with Michelle, that when patient family says that don't tell the patient, how do you handle that? So what I recommend here that you must address this. Don't just accept what they say. It's very important to ask them why and what are their concerns. Usually they'll say the patient will not be able to, accept it or will not be able to tolerate it. So Michelle, when you were giving this answer that in the male ward, it's usually the female attendants who are handling. It could be the mother or the wife or sister who are looking after the patient. That itself shows that they are going to lose a member of their family. They are not only preparing themselves, but they are still looking after the patient with the hope that the patient might come back. So we underestimate the human power and human tolerance. And also, like I said, if you help them see why it is important to disclose so that the person can do whatever their last wishes are and they can, take a call. And of course, legally and ethically also, we are obligated to get this request from the patient. The patient says that don't tell me, tell my family, I don't want to know about my disease or my condition. Then of course you have to respect the patient's decision. Now coming to the performance, as I said, it has to be in an honest and very clear manner. But then at the same time, it has to be done in a very sensitive manner. Because when you say something, that's going to actually cause a dent in the person's mind. So we have to be sensitive, but at the same time, we need to be straightforward, because any, attempt to minimize this severity or soften the blow will create vagueness and confusion. So the last question they will always have is, I hope the patient will be fine. I hope the patient will recover. I hope the patient will be free from this disease. So we have to be very, very clear on that. But of course, we need to be sensitive. So balance between sensitivity and honesty, and avoid giving any precise answers. Kitna time hai? 6 mahine. And we have seen a lot of time, they say 6 months and the patient lives for 3 years. So it's always, advised to avoid any precise answer. So maybe you say that usually in such cases, it can range from this to this time, rather than giving any specific timeline. And then don't take away all hopes. When you say nothing will happen, nothing can be done, you are in the last stage. So you're literally actually taking away their last hope. So there has to be some way to give them some way of hope and optimism. So when you're explaining them about their disease condition, make sure that you use simple language, avoid technical jargon, avoid single steady monologue. It should be a dialogue. They should be given a chance to speak, to ask, or to express themselves. So therefore, make sure that you pause frequently and you allow them a chance to say. It will also give them an opportunity to process what we have said, because it has come as a shock. So they will take longer to, take that in. And then, of course, in between, your silence and body language plays a very big. The way you sit, the way you move. For example, if your hands are closed and you're sitting like this, it shows that you are, I mean, you're just doing this more like a mechanical move. Or if you're rocking in the chair and talking, again, that would kind of disturb and distract. And having phone in your hand and doing the talking, if you're holding your phone in hand and you're talking, or in between you're looking at your phone, even that can be very distracting and very disturbing to the family. So body language again plays a very big role. So, and when you're talking to them, make sure that you check for understanding. So when we are talking about the body language, we have discussed at length in the previous classes about the right body language. And let me remind once again, only 7% of the communication happens through you. Most of the communication is through your tone of voice and your body language. So make sure that your body language is appropriate to the occasion. So when you're leaning forward and you're nodding in between and you're slow and your volume is slow, your tone of voice is slow, and you're making eye contact, that shows that you are building connection with them and you are giving them time and opportunity to absorb and express themselves. So greeting softly, offering them place to sit. Establishing eye contact here is very important. Why is it important? Why is it important to make eye contact?
Shows active listening.
Sorry?
Active listening.
Okay, active listening. That shows that you are listening actively. Yes. What else?
We can come to know that what kind of communication we are having with the patient, whether it's a passive or passive aggressive or assertive. So by looking at the eye contact, whether they
So you get to
are
observe
making
their
contact
body language
eye
and
contact with us or they are looking other way.
when do we
Uh,
avoid eye contact?
Yeah.
so the eye contact, if you're having an eye contact, it says at some point you're talking the truth. You're not hiding anything.
Absolutely. So when you're not making eye contact, it at times communicates that probably you're avoiding to make eye contact. You're not confident, or you're hiding something, or probably you're responsible for the outcome. Somewhere you have failed and you are, conscious of that. So making eye contact is very important. Posture plays a very big role. As I said, open posture, leaning forward, tone of voice. Again, if the tone of voice is authoritative or aggressive or intimidating, the whole communication is going to fail. Even when they accuse you of not looking after or not doing enough or being, late in responding to the patient's need, when you're handling that situation, your tone of voice can calm them down or can aggravate the situation. A lot of time they would want to express. Letting them express is a good way to let them vent their feelings. Also, you will get an idea about what they are thinking or feeling inside. So when they are talking or saying something, listen attentively. Uh, showcasing that yes, I am understanding your concern. And when you nod, it shows that yes, you are listening, understanding, agreeing. And a lot of time you can just accept emotional reaction without being too reactive. As I said, if you give them a chance to vent their feeling, even that's a good way to calm them down. Then, of course, uh, comforting the patient or the family with appropriate verbal and non-verbal gestures. So, a lot of time when you put a hand on their hand, if it is appropriate, if it's a female therapist and a female patient, you put a hand on their hand or on the shoulder or on the head. That kind of calms them down and also shows that you are with them in this situation. So, how do you start the conversation? Dr. Pradeep, any specific way you use to start your conversation with them?
Ma'am, basically, just like a normal greet the patient, then tell
Mhm.
the condition, tell the condition. We may start with the that these are the reports we are waiting for.
Mm. Yeah, I know this is not normally how we start in India. I think you are very right. This is how we straight away start discussing about the report, that this is the report and the report is really not very good. These are some ways that can help us, communicate in a more compassionate manner or empathetic manner, where you kind of express that even you feel bad to tell this. Uh, like for example, when you say your reports have come, but unfortunately they are not very encouraging, or I'm afraid the reports are really not very good. So when you talk in this manner, do you think this will help communicate your being with them? What do you say? What do everybody say? Why only Dr. Pradeep or others? What do you think?
I think it's about being able to articulate it in the regional language.
Yeah.
Because I feel like a lot of things in English sound great.
Yeah.
So, I mean, that is one of the many things that happen, but it definitely gives them an opportunity to show that you want to be sensitive about what you're going to say.
So I'm not saying exactly this is how they should be, used, but then in some way where you kind of don't just go and tell भैया आपकी रिपोर्ट आ गई है अल्ट्रासाउंड की और रिपोर्ट तो अच्छी नहीं है ना आपकी भैया एमआरआई की रिपोर्ट आ गई है पर आपका तो पूरा फैला पड़ा है पूरा उसमें so I mean it could be little more a humane approach when you talk that's the whole idea so when you say कि जहाँ आपने टेस्ट करवाया था उनने कुछ बताया आपको कि क्या है रिपोर्ट बताया तो नेचुरली जैसे नहीं उन्होंने कुछ नहीं बताया हाँ एक्चुअली रिपोर्ट बहुत अच्छी नहीं है तो इसलिए उन्होंने भी आपके साथ डिस्कस नहीं करा बट उन्होंने पूरी रिपोर्ट मेरे साथ डिस्कस करी एंड देन यू टेक इट फॉरवर्ड Maheshwari, I think I should speak in English for you to understand. So what I'm saying that you will have to start with something and then take it to the point where you help them know that the report is not okay. Usually it's when you get some tests done and for example, you got a biopsy report or some MRI report, and then you talk about the report. So start like this. So how does the bad news hit patient? How do you think patients react to it? How does it hit? I think you're on mute mode, Michelle.
Yes.
Shock.
Shout? Yeah, that's one common way, of course.
It's a shock or denial of
Shock.
hearing the news.
Shika, what has been your observation? When you give them bad news, how do they react?
Shocked.
Mitu, what do you say? What has been your
So I
observation?
think when the communication throughout has been stronger with them and we've been regularly communicating the how is the patient health doing, at that point of time, it's not at one point they realize how the condition is.
Mhm.
So maybe I've seen very extreme cases, so that's where I think.
Actually, bad news results in cognitive, behavioral, or emotional deficit. It's like blank or blackout kind of thing, where you don't know how to react to it, how do you really respond. So the person who is delivering the news, of course, cannot change the news, but how you know, handle that, either you can make it better or you can worse. So when it comes to how do people respond, actually you're right, almost 50% of them respond being shocked. They're not able to believe it. Again, a good number feel frightened because now they start worrying what is going to happen. Is it something serious? What is the lifetime ahead? Almost one-fourth of the patient reported being sad. 40% of them accepted it as their fate, and then 50% of them said that they were not worried. But you can see most of the people, they are either shocked or they are scared of the diagnosis. And when it comes to how do they react, a lot of them start crying. They may suddenly become silent. They may start asking you, are you sure? Have you checked the reports? Could it be wrong? Would you like to get the test done once again at another place? Could there be some mistake in the report? Or a lot of time they'll say, don't tell my husband, don't tell my wife, don't tell my parents, don't tell my children. So that's how they will react. So the psychological response to this is called DABDA, that is denial, anger, bargaining, depression, acceptance. That means initially they will be in shock and denial, so they will not believe that this is true. And then they will be angry, unhappy, aggressive, or revengeful because they want to now blame somebody for the situation. And then when the reality sets in, they start bargaining. Can we take the patient to another hospital? Can you please try once again? Can we try some other treatment? When they realize that, there isn't much that can be done, then they suddenly become quiet and feel low, and then finally they accept it. How do you handle these situations? How do you handle these responses? Denial has to be, responded with information. So you need to provide information to help them see the reality. When they're acting angry or aggressive, we have to stay calm, listen to them, and support. Unless they are violent. If they're violent, of course, you have to look after your safety. When they're bargaining, then I think we need to help them to see the reality using empathy and asserting. And then when you see them, becoming quiet and depressed and kind of feeling clueless, that is where you need to give them direction, what needs to be done next. And when you see them accepting, we have to encourage them for the role that they are playing in the patient. So at this stage, I think empathy I've been talking about. That's what we need to really bring in here rather than being annoyed with them or unhappy with them for not believing, not accepting, acting aggressive. We need to see that this is how the human mind processes any bad news. They have shock absorbers inside. Denial is one shock absorber. Anger is second shock absorber. And then slowly, then the bargaining is the third shock absorber. And then finally they start, kind of feeling low and defeated. And then come the final stage, etc. So rather than being annoyed with them that they are acting aggressive or they are in denial and they are not accepting the reality, You have to give them time to process and then communicate with understanding and give them time to come to a final point. So when the patient or patient party is in that stage of dab, it is advisable not to leave them in between. It is advisable to be with them in those hours till they come to the point of acceptance. That's where you can assume that now they're going to kind of take it further and start working. So empathy can be expressed in many ways when you say something like this. I know you were not expecting this. I know even I was not able to believe that something like this actually would happen. Even I was hoping for a better result. Again, these are ways to kind of communicate that you are with them in their hours of crisis or pain. So a lot of time in the death is recognizable. You can actually see that these are the last few hours. Again, we need to have a lot of compassionate honesty in community. We know the patient has this last few hours. So make sure that you allow the family members to meet the patient because that's the probably only time left for the family to see the patient alive. Evaluate what their needs are for support and also provide empathetic support and attention if they want to kind of do some ritual before death. For example, somebody wants to give Ganga Jal or some ritual, and if you think it's not going to interfere with patient care, we can accommodate that. Sometimes they want to have a prayer or something. So if that is possible, doable, I think we should allow that. When it comes to announcing death, again, one should try to do it in person as the person who has been the care in charge. Be honest, be there because physically being there around would comfort them that you are with them. Again, you can check with them about their cultural or religious beliefs or rituals that they follow. And if possible, if you can accommodate, go give them the permission to do that. So if you're going to talk about funeral or, for example, you need to talk about autopsy, then you need to be very sensitive and careful when you're going to talk about it. In case if you watch any unusual grief reaction in the patient or in the family, then I think you need to take appropriate action and seek the support system that needs to be done. So as I mentioned earlier also, the breaking of bad news has to be done by the treating doctor, but the residents, nurses, and other paramedical staff play a very big role in this situation. So we need to be more, responsible, more composed in that situation. If we appear to be casual and not affected by it, they kind of wonder that are we not affected by the pain around us, the suffering around us, or the seriousness of the situation. So at least that calm, composed environment can be maintained, especially when there is something very serious. Also, in these hours, I think we need to be more understanding and accommodating to the families' needs. I think clinicians, when they are doing it, there are a lot of underlying thoughts and emotions going on. So a lot of time one feels uncomfortable about the family's expectation and the patient's expectation that they were hoping that the patient will make up. But once you see that the patient is not doing well, you are going to actually destroy their hope and the family's hope. Also, when you feel incompetent or inadequate in the face of uncontrollable disease, it gives a feeling of helplessness. And then one is not prepared to manage the anticipated emotional reaction. I've deliberately written anticipated emotional reaction. If we know and if we understand that there will be emotional reaction and we need to be prepared for it, I think most of the situations can be handled very well. And then sometimes we have painted a very optimistic picture about a procedure or something. And if things go wrong, we feel bad about the outcome. I remember one of the eye chain had a tagline, घर से आइए सर्जरी करवाइए ऑफिस जाइए. come from home, get the surgery done, and go to your office. So I'm sure when they had some nucleus drop or vitreous hemorrhage, they must have realized that not all patients will have 100% outcome. So they stopped using that tagline. But we have to be, careful when we are promising our patients about something like this. So remedies for these is, please give realistic expectation to your patients. Accept your professional limitations. We are not gods. We can do our best, but cure is in his hands. And then learn to control emotional reaction. We can't control the reaction coming from that side, but we can definitely control the way we react to the situation. And then, of course, the family needs to be kept in loop, updating them regularly. Will prepare them for eventuality, especially where you know the prognosis is poor, patient is not going to make. It's better to prepare them right from the beginning so that it doesn't come as a shock. And then, of course, make sure that you document all communications. Because if you don't communicate, if you don't document, there can be a legal problem. And you can make it. Common mistakes that we make in breaking bad news, you will see that people try to avoid breaking the bad news as long as they will not share the news with the patient or their family member. So just not doing it and hoping that someone else will do it. Let मेरी duty खत्म होने वाली है, my duty is going to be off. So let the next person who comes in, they should break the bad news. Or they may either tell lie or they may be very economical with truth. So they may not actually tell the truth. Deliberately, they don't pick the patient's cues. If they can see some emotional reaction, they will not pick the cue. They will not respond to it. And then, of course, a lot of us do the activity in a very, very mechanical manner. Once you break the bad news, the patient fears that they're going to be left, they're going to be abandoned. It's very important to let them know that they're not going to be abandoned. They will be referred to the right person for the continuity of treatment. And especially if our setup do not have the treatment facilities for such cases, the patient will have to be moved to another setup. So establish a plan, and in case if there are some current symptoms that need to be treated, make sure that you treat those symptoms. Discuss the next treatment, what is going to happen, how they're going to handle, who is going to look after. Then establish a time for a follow-up appointment. In case if they want to come back for follow, you can establish a time for follow-up. So when it comes to arranging for the referral, so make sure that you arrange for appropriate referral. If possible, give contact details of the next person to whom you are referring. And if you can call on their behalf and let them know that this patient is referring to you, they feel that somebody, has been properly handled over. Of course, make sure that you make a proper summary and hand over all the reports and tests that has been done. So involving, and creating some support system, having like family, friends, social workers, spiritual counselor is a good idea, because a lot of time we know we are not able to handle emotions or provide emotional support time to time. So there has to be people who can manage this. So to summarize, most of the patients want to know, and if done rightly, I think it improves the doctor-patient relationship. The breaking of bad news should actually be done in a manner that they get to know whatever they need to know about their condition. It would help the family and the patient to cope up with the situation. It will also foster a collaborative relationship between us and the patient and will prevent replaceable death. 6 steps that we have covered is prepare yourself, prepare the patient, prepare the place, find out what the patient wants to know, find out what the patient already knows, and then share the information, respond to the emotion. I've underlined it because this is one thing that we avoid doing. So make sure that you identify that the patient is emotionally overwhelmed and you handle those emotions. And then do proper planning and follow up. Disease and death, how they affect anybody, we can only know if we have personally experienced something like this. I don't wish anything of that sort for anybody, but I think that changes our perspective and our viewpoint. So let me stop the sharing. Where is it? I'm not able to locate. That is a panel. Yeah. They've changed the arrangement of the keys. I was not able to see the stop sharing option. Okay. So this is in detail about the topic that we have discussed. It's a very important topic, so I normally spend a lot of time discussing. Any questions? Any points that you want to add? Any questions you want to ask? If no questions, then we start with the presentation. Shikha, are you ready with the presentation? Shikha and Michelle, both of you. The Deep has written a message. Let me read. Yeah, that's so wonderful. Thank you, Dr. Deep, for writing this message. Thank you. So, Shikha, if you're ready with the presentation, and if that app is not working, let's skip that point because we are already kind of. I can see your son seems to be interested in disturbing you and coming in the frame. I know it's difficult to. They have to really act very patient. 2 hours they're in front of the camera and they can't come in. It's difficult for them also to control. So Shika, I'm giving you. You can share the presentation if you want to start. Yeah. Yeah. Okay, any challenge?
Yes, ma'am. Where I can share my, because I'm not seeing my desktop over here. No, but here only Microsoft SharePoint and Google Drive, but I am able to see my screen, the desktop that I from which I have to share the things.
So Michelle, I think uh, Shika has some challenge with her laptop. not a laptop, but presentation.
Sure, ma'am.
So maybe you can start. Uh, Shikha, you email me the presentation and I will share on your behalf. But meanwhile, let Michelle do the presentation. Go ahead, please.
Yeah. Just share my screen.
Yeah, you can share your screen.
Yeah, it's visible.
Yes, yes.
Okay. Right. So, good evening, everyone. And my topic that I have chosen for today's presentation is on reflective questioning. So I'm basically going to cover an activity, two about a brief about or definition about what exactly is reflective questioning, where we can use it, some of the advantages and disadvantages, and finally, some of the things we should do and we should refrain from doing. So we're going to quickly move into this activity. I'm really sorry that I'm making you reflect like at a time where I'm sure everybody's really tired and wants to kind of go into bed. But very quickly, we're going to do this. So I have a couple of instructions. So I request all of you to take just 1 minute to reflect on this question, which is about how has this course um, basically impacted your understanding of communication skills training, especially in a healthcare setting. At the end of 1 minute, I have a specific question which will help you reflect on it a little more closely. And each person will get a different question to reflect on. Remember, there is no right or wrong responses, as this is your own understanding of your experiences and feelings from your point of view, right? So can we just take a minute? If you'd like to put your cameras off, that's totally fine. So I'll give you a minute to reflect. All right. Can we all just come back? I hope it gave you some time to just think through um, how the course has impacted you in terms of your understanding. So, Dr. Pradeep, I have a specific question for you. How would you say that this course changed your attitude about communication skill training?
So basically, I come to know the meaning of empathy. That putting yourself in the shoes of others when you are on the other side of the table. So what your patient feels, how will you react? It changes the whole scenario.
Okay.
So taking patient at par, active listening to him or her, it makes a difference.
All right. Thank you for that. Shikha, if I were to ask, what have you become more aware of as a result of this course?
चाहिए मैं वो पेपर और something went
Shikha, you
wrong.
want me? Sorry, do you want me to repeat the question?
No. Am I audible?
Yes, now you.
So the best part is how to handle the situations I mean, in terms of the questions that people used to ask and how to train them, especially.
All right.
Because as an administrator and a trainer, I can understand the things, how to frame the sentences well to make myself more clear.
So you become more aware of
Yes.
your behavior and what you need to do about it. Okay, thank you. Maheshwari, my reflective question to you is about, was there anything that you were surprised about when you joined this course?
After joining the course, mission,
Yeah.
yeah, I was like surprised with two things where when we have a conversation with a colleague or a team member,
Hmm.
we have to think, be empathetic and be very clear and confident what we're going to communicate with them. I mean, um, when I was taught, when during my our first, second or third session, I asked a question to Dr. Indu ma'am about my staff was not happy in the environment, and she said I was like totally focused on the customer uh, side, but what she educated me was like you have to be supportive to your team first, and then the customer comes the second. So in that way, I was like very surprised, and I have changed my attitude in that angle totally from that moment. So
Okay.
it has surprised my changeover. Yeah.
Okay. Yeah. Thank you
Thank
so much. Ashia, uh, was there something specifically that you related to when you did this course?
Specifically that I relate to. I think I would say it did because I come from a consumer's perspective. I've not worked in the healthcare setting as such, and my interaction with clinicians has been limited to as a patient or as a caregiver or something like that. So it's always one-sided view. But for me, I could relate to the other side of the story.
Right.
How it is difficult, how complex it is to interact with patients for doctors as well. It's not,
Right.
when we say, the doctor does not have empathy, there's so many factors that are going on there. And for me, it really made a lot of sense. So, it's like living the experience and seeing, being in a doctor's shoes or a clinician's shoes and understanding.
Right.
And if I happen to give trainings at some point of time in the future, it would really help me understand, I mean, interact in the same manner.
Right. Okay. Sure. Thank you so much. So it's more like you related to being on the other side and what you can incorporate into your own treatment. All right. Yeah. Thank you. Indu ma'am, am I allowed to ask you a question?
Sure.
Right. So my question is about what have you specifically empathized with as a result of doing these communication skill trainings?
So I think I have actually developed deeper understanding of the challenges of even healthcare professionals. Because a lot of time the challenges they are facing in their situation is probably not very well understood by general public. They are not able to see, for example, if doctors are working for 12 hours, 16 hours, it's inhumane. And then we expect them to have very ideal behavior. It's very so, and also, for example, I see nurses and other staff, working and not being compensated enough. I feel for them that they're doing their job well. That why not be fair to them for the financial compensation or their reward or their acknowledgement. So more I'm trying to connect with them. More I'm able to empathize with their status situation and see how I can empower them with the right skills. Yeah.
Okay. Thank you so much. So that brings me to the end of the activity. So thank you all for all your inputs and answers. So typically, I just want to bring our focus, since we're learning about the pedagogy, about what was the rationale behind this, right? So Basically, this is a 3-minute pause. When I discussed it with ma'am, I know we are already short of time. We are eating into extra time. But I brought it down to 2 minutes. So it primarily allows people to just stop, like literally stop all the other thoughts that are kind of there in your mind. The second thing it does is to help you reflect on specific concepts or ideas that have been introduced. Hence, I brought in that particular question in the beginning. But obviously, my specific questions to you were a little different from what you had originally thought about. And the third part is to try and help you make connections to the existing knowledge that you've had or the experiences that you've had. And I'm sure, and I think all of you heard each other out where you saw that each person has come from different backgrounds, you have different experiences, and this has kind of molded or changed or modified the way in which you have thought of things or reflected on things from what you had before to what it is now. So typically when we try and understand what exactly is reflective questioning, so it's basically a metacognitive process. As a psychologist, metacognition is basically to think about how we think and how we learn, right? So it's kind of going a little bit more deep rooted to understanding one's own sense of self, the other person, as well as the situation, and the two things. So it basically tries to focus on self-awareness and also our own understanding. So from a so-called definition point of view, it's a way to be described as the way of asking specific questions, which helps one think about their thoughts as well as their actions. So I found this kind of easier framework that all of you can use either when you are reflecting about things or with groups. So basically there are these 4 open-ended questions that you can focus on, which is first with awareness, and that's what our activity was about, which is bring into conscious awareness about what you already know, what you're already doing, and typically answer the who, what, when, and where questions. The second thing you could do is go into a little bit more further, which is analysis. So comparing what you know now to what you want to do or the outcomes or the skills or the knowledge that you want to move towards. And then you have something like called as the alternative. So reflecting on possible ways on how else could you have achieved, your desired outcomes, or what could have been the other ways in which things could have been done better. And I think ma'am has used a couple of these questions even to us during the course about how different would you have done it? And I think our role plays were an exact chance to kind of think of what else could have been done or modified. And the last thing is about action. So specifically look at what actions are people willing to take to reach that desired outcome. So we can use reflective questioning based on all of these open-ended questions. And where can it be used? So primarily reflective questioning started out being used mostly in educational settings. So in school or colleges where there is more conversations about, what the learner is really experiencing or feeling. But definitely if you see there are so many other specific areas in which it can be used, like healthcare consultations. It could be like what I do specifically, which is counseling as well as therapy. It could also be specific to appraisal meetings. Sometimes when there's a need to resolute or bring about some kind of conflict resolution. And finally, when there is, feedback that needs to be given to people about either how can they develop better in a team or their personal development. Sorry, the power is gone here. That's why my camera is off. So just a couple of things to remember. So when we look at the advantages, remembering that it helps us to enhance our understanding about people in that particular group and improves the communication as well as the interaction, and definitely leads to better brainstorming and problem solving. People also feel a sense of being empowered, like, they've been given an opportunity to speak their mind. Coming to the disadvantages, if you have a bigger group, self-reflection can take up a lot of time. There could also be potential for misunderstanding because not 2 people in that group might relate or talk or share the same thing. So there can be misunderstandings if there are very varied opinions. Some people are not very keen to share their personal experiences or feelings in a larger group. So there's going to be emotional discomfort, and sometimes people can share a lot. So how do you cut that and break it down is something that we need to look at. And finally is to look at what are some of the things that we engage in. So that's basically creating a supportive environment and telling people it's safe to share, that things that they share here are not going to be told outside. Using of the open-ended question and basically listening actively and validating the responses. Some of the things we shouldn't be going into is interrupting or rushing people's responses. Sorry if I did that to any of you because we're on time limit. Also labeling or judging people's reflections, because that's something that many times it tends to happen. Either people in the group or the person who's facilitating can say, oh, that's not an appropriate reaction to have. And that can be a cause of them not wanting to share as well. And finally, about don't overuse reflective questioning. So constantly asking them, what do you think? What do you feel? Tell me more, how would you have changed it? Can get also very frustrating because it really just makes things go in circles and we don't really come to any kind of definitive conclusion. So with that, I'd like to say thank you. If you have any questions, I'm happy to.
Any questions for Michelle?
No
I think
question. I would
Well-
be very,
Yeah, sure, go ahead. Yeah.
very well presented, very comprehensive understanding of how to do reflective thinking. Thank you.
Thank you so much.
Very simple, to the point, very crisp. And I think with adult audience, reflective questioning is a wonderful way to engage them. I mean, they will start thinking the moment you ask question, they will have the answer, they will start looking left, looking right, and then they'll come with the answer. And I saw everybody was looking upward, either left or right, when they were asked a question, because you think you really need to disconnect with the surrounding. and reflect on it. Thank you,
Thanks.
Michelle.
Yeah.
That was really good presentation. Thank you. So, Shika, are you ready?
Yes, ma'am.
So, do you think you'll be able to?
I don't think so. I will be able to present.
Have you emailed me
Yes, I have emailed you.
on my which email ID? Can you tell me?
Anijaindu@gmail.com.
Okay, give me one.
By that time, ma'am connects us. Let's start because we have a short of time. Let's do a small activity. We'll ask you 3 questions, fun activity it is. And let's start with, I just take one randomly. Maheshwari, I will ask you 3 questions and you have to reply me. So the texting or talking on phone?
Talking on phone.
Talking. Do you snore?
No, I don't know. Maybe the
Favorite
person
day of the
next
week?
to me. Sorry?
Favorite day of the week?
Saturday.
Last song you download?
I don't download songs.
Okay, thank you so much. This is one fun activity with Maheshwari. Let's start with Arshia. Arshia, do you snore?
Sometimes
Texting or talking?
depends.
How long does it take you to get ready?
5 minutes.
Okay. Question for all. What animal hibernates the longest? Bear, snail, snake, or sloth?
Beer.
Floor.
Bear.
Yeah.
Beer.
Second, how many colors are there in the rainbow? Dr. Pradeep?
7.
7.
Yeah. Why we did this? Apple ring.
You were feeling sleepy, so you woke us.
One of the reason when we start some seminar, some lecture, some session or training, we usually do one-sided. By asking such kind of questions, might be fun questions, and sometimes, not sometimes, but always related to the content, we should ask few questions to the participants also. So let's start with our presentation. Our presentation topic is quiz and rapid fire round.
Is my slide visible? Is the screen visible?
Yes.
Give me
Yes.
a second to-
Okay. So what is quiz? Any idea?
Short questions to test your knowledge.
Test. Okay. Anyone else? What about rapid fire round?
Are you able to see the slides?
We need to answer it quickly. Like,
Ma'am,
Within
it's
seconds.
coming with the
Yeah, it's on the click. Then the presentation. I'm sorry, ma'am, that I am bothering you.
No, it's okay. Only thing is, are you able to see?
Yes, yes.
Okay.
Manage, but I'm just sorry you have to do all these things.
No. That's good.
So, quiz originated in Dublin. It's formal. It's a informal test or set of questions that I have asked you earlier. Like one by one, I'm asking one question. I'm giving you few options, and that options you are choosing one. In that, you are taking some time, but the questions that I've asked you one by one, that is rapid fire round, where you don't have to take much time and you have to answer quickly. Now, rapid fire round, as you know, an interactive and fast-paced activity, involves asking a series of questions that, like I have asked Arshia, I have asked Maheshwari, involves asking a series of questions, then prompt answer you have to give quickly. That will not give you much time. Now, the next slide. What is the importance of quiz and rapid fire rounds in the training, seminars, or any kind of sessions? As you can see, anyone other than these two reasons? Questions are a great way to engage audience, we all know. As you said, if we are sleepy, and if I ask, Dr. Pradeep, do you know this? Dr. Pradeep said, oh, could you please repeat your question? That means he is not attentive. If you keep on asking questions, then everyone is attentive and with their open eyes. So there will be various kinds of questions and rapid fire rounds that you can use in our sessions, like multiple choice question, fill in the blanks quiz, quiz with report card, or any either ways. There are various apps that we can use, like Slido. One app that I've tried to use, like that I have tried, but it's the first time I was using it. But unfortunately, I should have used Slido instead of that particular app. Trivia Star, Kahoot, Canva, Google Forms. These are few of the apps that we can use it. These are the formats in which we can use the quiz PowerPoint, like option Y, A, B, C, or answer A, B, C, D, or yes, no. We can use true, false also. Like if we use rapid fire round, we can ask whether it's true or false. Now, can you tell me what is the do's and don'ts? I know it's all mentioned, but if you can quickly think about it and tell me. Maheshwari, could you tell me one? Other than these four that I have shown you. Michelle?
Mhm.
Quickly.
maybe a mix of not just questions, but maybe like words, pictures. Yeah,
Yes. In
to make it
quiz,
more fun.
yeah. What are the do's? Let your learner know up front how many questions. Like initially I told I will ask you 3 questions. So I should not go beyond that. If I said 3 questions, then I have to ask 3 questions, not 4, 5, 6. Now include questions that are aligned with the learning objective. If ma'am used a different kind of questions that is not in the content, then that question is useless. That we call as out of syllabus. So we should ask those questions that are related to our session. Design performance based, like you should always ask quizzes that test application of the skill. Create custom quizzes to engage your learners. That Michelle used, like, Chika, you have such particular question. Michelle, you have a particular question. So in this way, we can engage our audience. These are certain rules that we can use in our quizzes and rapid fire rounds. What don'ts, like true and false, not overuse of true and false, not overuse of multiple choice question. Ask negative questions. Don't ask negative questions like which one of these should you not do. Always like ask the passive thing. Incorporate trick questions. Don't incorporate tricky questions. Don't confuse the audience. It should be straight. Thank you. I know.
How do I stop hearing? I don't know. This is completely changed. I think now I should be able to do it. Stop here. They've changed the setting. They've upgraded the keys. Oh. Okay, I think. And any questions for? Sorry, there's my video. Yeah, questions for Shikha or Michelle? Anybody? I know everybody's feeling sleepy now.
You're hungry.
Good presentation, Shikha. Thank you. So I think I posted the feedback form in the group. I request all of you to give feedback maybe tomorrow morning in case if you are feeling very sleepy. But the feedback is not for the presentations made by Michelle or Shikha. It is about the topic that we discussed today. So I've modified slightly the feedback form. One point I've added. I want you to answer that. So we'll stop here and meet next week for the last session. So I request all of you to be ready with your feedback because I'll be asking you to give your what's your learning and how do you want to take it forward and implement what you're learning. So should I close it? Okay, good night. Thank you, everyone.